Congratulations to everybody who's listening. If you're here, that means you have a new bundle of joy coming your way. It's a very exciting time. It's also a little bit scary, but don't worry because we're here to help. I'm Dr. Carrie Firestein, Chief Executive Officer of Allied Physicians Group, pediatrician for 30 years, mother of 3, and recently a grandmother of 1. My grandson was born earlier this year, so I've gotten to see firsthand all the excitement and all the new parent questions. You're going to have a lot of questions, a lot of decisions to make. We're going to go over a lot of stuff today, but more importantly, we're going to give you a place where you can get answers. Allied Physicians Group is a group of pediatricians across Lower New York, and we have the ability to leverage our size to get you all kinds of support, either on our website or through breastfeeding, nutrition education, asthma education. We'll kind of go through that a little bit later. But tonight we're going to cover all the baby basics, and we're going to answer the questions that you've sent in, as well as any of the questions that you start to put through chat. So I'm going to let my esteemed panel introduce themselves tonight, and we're going to start with Dr. Karen Leitershore-Fuld.
Hi, everyone. I'm Dr. Leitershore. Congratulations on the upcoming birth or recent birth of your child. I am a pediatrician and a neonatologist. I spent several years working at Lenox Hill Hospital in the neonatal intensive care unit before joining Dr. Firestein at Pediatric Health Associates about 3.5 years ago. I have 2 children of my own. They're 12 and 8-year-old girls. So I've been through it, and I'm here to help you out with whatever questions you might have.
And I have to say, my daughter loves seeing you, Dr. Karen.
Thank you.
Dr. Svitek.
Hi, congratulations, as everybody else has said. I'm Dr. Scott Svitek. I'm been a pediatrician for 30 years. The first 10 were in academic medicine at Long Island Jewish Medical Center. And then I left there to join my current practice in Comac as Comac Pediatric Associates. I am the proud parent of 2 children, a 23 and a 21-year-old. I've yet to meet that milestone of Dr. Firestein of being a grandfather yet, but I do look forward to it. Enjoy.
And we were talking about the fact that you've actually had grandbabies in your practice, parents that have come back and brought you their children.
That is one of the joys, as I was saying before, of pediatrics is we get to watch children grow, mature from babies to childhood to teenagers to adults. And nothing fills my heart with more joy than seeing one of my kids come back as a parent and trusting their children into my hands again.
Thank you. Dr. Merkin. You're on mute.
I practice at MDs for Kids in Great Neck with my 4 partners and medical assistant and physician assistant. Been in practice for 35 years and still waiting to have a grandchild, but my baby is turning 34 tomorrow, so hopefully soon. You know, it's true, as Dr. Svitek said, we get to see 2nd generation patients and probably 3rd before I decide to retire. So it's been a joy and very happy to be here tonight.
Great, so let's get started. Can we start the videotape? And Dr. Karen, it's up to you.
Okay, thank you. So feeding is one of the biggest topics that we talk about in the first week after your baby is born. And it takes some time for the parents and the baby to get to know each other and sort of figure it out. So in terms of hunger cues, some of the things that you'll be looking for are that the baby will be rooting, turning their cheek to the side, starting to open up their mouth, putting their hands in their mouth. And lastly, they will cry. And crying in a newborn is completely normal. So don't be surprised. And it's the only way they really have to tell us, you know, look, I'm really hungry now. So you can catch the subtle signs initially of them just waking and rousing and rooting. or it can progress to the point of crying. And sometimes that happens pretty quickly. In terms of how much to feed, so there's going to be the question of breastfeeding, bottle feeding, pumping and giving express milk by bottle versus formula by bottle. And those are all decisions that you and your partner will need to make in those first couple of weeks. And it's not easy. It sort of comes upon you very suddenly, even though for all these months you might have been talking about what you plan to do, things may change in the first couple of weeks. And that's okay. We're going to be there to help guide you. And we also have a lactation consultant in Allied and in some of the practices if there are specific breastfeeding questions. So the baby's tummy is really tiny, and they're not meant to have very much in the first week of life. In fact, the babies are going to lose some weight in the first week. They can lose up to 10% of their birth weight. And then by the second week, we expect them to start to regain their birth weight. It's important to be feeding the baby at least every 2 to 3 hours if breastfeeding. If bottle feeding, just with formula, sometimes you can get away with every 3 hours. But it should be at least every 3 hours with the bottle feeding, at least every 2 to 3 with the breast. So mom's milk usually comes in around the 4th day of life. And I hear a lot of moms say, why should I put the baby to the breast when there's nothing there? And it's actually the complete opposite. You want to get that baby on as much as possible in the beginning, in the first few days, because it is an issue of supply and demand. So the more you put the baby on, the more you pump, the more or the faster that milk will come in, and the quicker you'll be able to feed that baby. Going along with that, it's completely normal for the baby to cluster feed in the beginning. And that is feeding sometimes every 30 minutes, sometimes every hour. They usually tend to do it at nighttime, so it can be difficult, but if you can get through those first few days, things will start to get better when that milk comes in. So again, you need to do what works best for you, your partner, for your baby, and that may change. So it's just something that we'll have to discuss in the first couple of visits. Usually we see the baby within 2 to 3 days after birth, and then a week later to watch the feeding and the weight gain. So how do we know that the baby is getting enough? There are a few things that we look at. We're going to be asking you about wet diapers. Initially, we say it's 1 wet diaper for each day of life. But when you get to about day 5, 6, then you're going to see probably 6 to 8 wet diapers a day, and that's going to go up to every feed by the end of the week. A bigger sign that the baby is getting the milk is the stooling. And so initially you're going to see the baby having meconium stools, which are black, tarry, thick stools, and that's from in utero. Once you start to see the stools transitioning over to soft, yellow, seedy, you're going to know that that baby is getting a good amount of milk. And then lastly, we look at the baby's weight. So again, they are supposed to lose weight in the first week. That is normal. But we want to make sure that they don't lose too much weight. And then we want to follow them until they return to birth weight. Okay. So sleep and SIDS. Newborn babies sleep about 20 hours a day out of a 24-hour period initially, really just waking up to eat. And this is totally normal. Sometimes you will have to actually wake the babies to make sure that they are feeding every 2 to 3 hours. in the beginning. This sleep time will decrease as they get older, and you'll start to see over the first few weeks more and more awake time, alert time, in which you'll be able to do some tummy time to kind of counteract what I'm going to talk about next. So safe sleeping. Well, I'm sorry, let me go back. So the quality of sleep. So babies do have their nights and days confused. And that's because when you're pregnant, you're walking around all day, kind of rocking them to sleep. So they're used to sleeping most of the day. And then when you're lying down at nighttime, that's when you feel them kicking. They're up and they're all over the place partying. So it does take some time for them to figure that out. And you can kind of make the environment in a way so that they know what nighttime is and what daytime is, even from the very beginning. In terms of safe sleep, in the 90s, one of the things that came out to decrease the risk of SIDS was having babies sleep on their back rather than on their tummies. And I'm sure your parents, your grandparents will tell you you slept on your tummy and you're completely fine. But we did see a drastic decrease in sudden infant death syndrome with the switch to sleeping on the back. So it's very important that we put the babies on their back. It is recommended that they be in a bassinet in the parent's room next to the bed, not in the bed. And in that bassinet should be nothing other than the baby and a swaddle or a sleep sack. And we'll talk about the swaddling in a minute. So they used to sell, and I think they may still sell, sets of crib bumpers and blankets and all of that. They still sell them, which is crazy, but they are not recommended. So you should not have anything in there, no blankets, no pillows, and no bumpers. Just like this picture should be the baby. Swaddling it's really part of developmental care. And it's very important. And most babies love it because it makes them feel safe, secure, like they're back in the womb. The NICU nurses are by far the best swaddlers that I know. I would love to learn how they do it, but basically you can do a tight swaddle. You don't want to do it too tight so that the baby cannot move around, especially with the legs. The arms, just like in this picture, that's how I recommend people do it, with the hands together and up by the mouth, because that's where you want the baby to be, midline. And then the legs a little bit bent, definitely not completely straightened out, and with some room to move. Sleep sacks are also wonderful if you're not able to get the swaddling technique right. And they make sleep sacks in all sizes. There's different ones with the arms out, as some babies within a few weeks prefer their arms out. And the other ones with Velcro, where you can keep their arms in if that's how they prefer it. But we can certainly show you in the office how to swaddle when you come in for that first or second visit.
Karen, if they go to, I just put in the chat, alliedphysiciansgroup.com under education baby basics, I have a swaddling video that shows how to swaddle, and I have my advanced swaddle technique, which people thank me for every day. So,
okay, great.
I guess I'm up. So under grooming your baby, generally your pediatrician, before you go home from the hospital, will go over all these things. So don't feel like you have to take notes, or certainly if you don't get this in the hospital when you go home, your first visit to the office, they'll go over everything for you. With diapers, you can expect to need a lot of diapers. Most parents are using disposable diapers. And as far as the baby's concerned, I think it's the best thing for their skin. That said, if you're a cloth diaper fan, more power to you. Whatever, you know, if the baby has a little trouble with diaper rash, I'm sure the pediatrician can take care of that. We do normally tell you, be very generous with the Vaseline on the rear end, especially breastfed babies tend to have lots and lots of bowel movements. So you're going to need lots of Vaseline. If the baby develops a little diaper rash, despite the Vaseline, there's a whole slew of diaper rash ointments and creams that generally, they all work very well. Although you may find that Decidin works for your baby better than Balmex or A&D, but you'll sort of have to get a feel for what works best for your baby's skin. With nails, I always tell the parents, no cutting or clipping, certainly in newborns and young infants. We get a lot of calls about bleeding fingertips. So you're best using a baby nail file or the fine side of an emery board. And you'll have to file quite a bit because the nails grow very quickly. With the ears, the first thing I tell parents is that the only authorized use of a Q-tip is in the belly button. Otherwise, for the ears, you can use your thumb, you can use the corner of a washcloth, but you don't really want to stick anything in the ear canal. The wax is meant to be there to help protect the skin of the ear canal. And with most kids, that wax will gradually work itself out of the ear canal. So you may see a lot of wax on the outside of the ear canal, and then, but that's normal. That's how the wax gets out of the ear canal. So that's fine to clean that off, but don't get tempted to stick a Q-tip into the ear canal. Umbilical cords, we used to have a whole routine we used to have the parents do with cleaning them and everything else. Nowadays, they actually found that the best thing to do is just keep it dry. You don't even need to use alcohol on the cord, and it'll dry up on its own and it'll eventually fall off, usually in a week, sometimes two. Once the cord falls off and it'll dry up, and then you're all set. There may be some dried blood in the belly button, and that'll come out in the bath once you're bathing the baby. If your baby is circumcised, well, I should say, as far as circumcision is concerned, if it's not a religious thing and you have the option to circumcise or not to circumcise, I usually tell the parents to take the father's lead. So if the father's not circumcised, I usually tell the parents leave things alone so things match. And if the father is circumcised, go ahead and circumcise the newborn. There is some data showing that circumcised males have a lower incidence of urinary tract infections, but the American Academy of Pediatrics doesn't feel that is significant enough to warrant routine circumcision. There's also some data in less developed countries that circumcised males may have a lower incidence of HIV, but most of us don't consider the US underdeveloped. So I don't think that's a real concern in our country. With skin, baby skin is very sensitive. Your baby can sometimes develop a rash just from touch, touching if daddy has a beard, or you're wearing a rough sweater. Sometimes you'll see the skin turn red or a little swollen. So, most of these things, if you just keep an eye on it, the rash will go away in a few hours. I usually tell the parents to just buy any mild baby soap, Aveeno, Aquaphor, baby wash, or even Dove for sensitive skin. And before the circumcision is healed up, and on girls before the cord has fallen off and healed over, you just sponge bathe and you try and keep the cord dry, keep the circumcision dry. And once everything is healed as far as the cord and the circumcision, you can go ahead and give a regular bath. The frequency is really up to the parents. There's, and your baby. You have to see how your baby tolerates bathing. You don't necessarily need to bathe the baby every day, but a lot of babies find it soothing, and sometimes it's nice to have a regular bedtime routine. So you sort of have to play it by ear and see what kind of skin the baby has, and adjust things from there. I should have mentioned with the circumcision, normally when after the circumcision, I usually have the parents buy the small 2x2 gauze pads. And whenever you change the diaper, you don't need to clean the penis. You just get ready with the new diaper, put the Vaseline on the rear end, put a glop of Vaseline on the gauze pad, plop it on top of the circumcision, and then you're all done. If you're breastfeeding, it's an easy way to keep track of how many wet diapers the baby's having. And usually that'll heal up in about 4 or 5 days. So I believe I'm done with grooming.
Should I worry, Dr. Merkin?
Should you worry? Oh, I'm doing that too? Okay. No, you shouldn't worry. Well, so when I send you home, when you go home from the hospital, I tell the parents that they should have a rectal thermometer in the home. And they don't need to routinely take the temperature. And from our point of view, if the baby looks sick, we don't really care what the temperature is. So baby looks sick, call us. On the flip side, if the baby looks fine, but you think the baby's unusually warm, then I tell the parents to check the temperature rectally. If they get a temperature of 100.4, 100.4, I tell them that's an emergency. They need to call right away, particularly the first 2 months, sometimes 3 months, 2 to 3 months. Even if the baby looks like a rose, 100.4, you need to call right away. But otherwise, you don't routinely have to check the temperature. Hiccups are normal in a baby, and I'm sure most pregnant women have felt the baby hiccuping even in utero. Hiccups just mean that the baby's stomach is full. It can be full of milk, it can be full of air, and you almost never see a baby cry with hiccups. So I usually tell parents, just ignore it. Your baby's fine, they'll stop eventually. Sneezing is also normal. That's the way the baby clears the nose. You may see a little mucus come out, all completely normal, nothing to worry about. Periodic breathing, that's when the baby, you may see the baby's breathing rate pick up for a minute or two, or you may see it slow down for a minute or two. You can, even while they're sleeping, it may depend on what sleep stage they're in, but again, nothing to worry about. Eyes crossing in a newborn is also very, very common. You're gonna see it. Babies, when they're born, are very nearsighted. So you can see their eyes move in 2 different directions. That's normal. As the baby gets a little older, the first few months, the baby will get better distance vision. So you'll see crossing less and less, and you'll start to notice that the baby will start to follow you with the eyes more and more, and be able to see, be able to do that even when you're further away. Generally, every time you come in for a checkup, the pediatrician is going to look at the eyes and make sure that they start to focus together. But that takes a little while. Initially, they can go in all directions, each one independently. So nothing to worry about.
Okay, I guess that's me. Hello, everyone, again. First thing I'm going to talk about is visits to our office. So we are hoping that as you're going through pregnancy, everything goes perfectly smoothly, no complications, no issues. You go to the hospital, have a nice, normal vaginal delivery, everything once again perfect, and your baby goes home, usually in 2 to 3 days after birth. In the days of COVID, where there may be desires to get the moms and the babies out of the hospital a little bit quicker to prevent an exposure to a COVID patient. You may even be leaving the hospital about a day or two after the baby's born. After you go home, we'll be seeing the baby in the first couple of days of life. What day exactly will depend a lot on what happens in the hospital. If it's a perfectly fine, no complication delivery in hospital, of course, we'll usually see you 2 to 3 days after you go home. If there are some concerns, we may have you come on in even a day after you go home just to make sure the baby's fine. And these could be if the baby is a little bit jaundiced, having a little bit of yellow color, or if the baby loses a little bit too much weight, the doctor that saw him in the hospital may just have concerns and want us to take a look sooner. So when everything comes on and goes beautifully, we have you come into the office. There are several stages to every visit, and pretty much every WellCare visit has all the same stages, just different what we do during them depending on the age of the child. So the first stage is you come in the office, usually one of our staff, a medical assistant or a nurse will take the baby into a room, do some objective measures. They'll measure the baby's height, they'll measure the baby's head circumference, and measure the baby's weight, just to make sure that the baby is growing appropriately and doing everything we want it to do. After that is done, that's usually when the physician or the clinician will come on into the office and do our part of the visit. We start with what's called a history. At this point, we'll be asking you a bunch of questions about what the baby's doing. And these questions all, once again, have about the same theories, just different questions depending on the age. Questions will always stem around, how's the baby feeding? So as Dr. Literature had said before, in the beginning, it may be if you're breastfeeding, when to increase or how to tell the baby's breastfeeding appropriately. If you're bottle feeding, when are the appropriate times to increase it? As the baby gets older, when's it appropriate to add in baby foods and other foods and dealing with those things. Each visit, we're going to be asking a bunch of developmental milestone questions. This is our way of making sure the baby is developing and doing everything we want the baby to do. We're also going to ask about bowel habits, urination, physical signs that the baby's doing well. During this point, we really want you to ask questions, or we'll even ask you, is there anything that concerns you about your baby? When you're in the hospital, you have this beautiful baby, everything's perfect. When you're home, you're looking at this baby 24 hours a day, you might notice the subtle imperfections that you didn't see at first. And we want you to ask the questions so we can address that when we get to the next stage of the visit, which is the physical exam. When you come on in for the exam, during the exam, we'll examine the baby from head to toe. Look at the eyes, ears, nose, throat, listen to the heart and lungs, do a thorough exam of the abdomen, look at the baby's genitals and make sure everything's developed okay. If the baby has been circumcised, and make sure that it's healing appropriately, and even examine the hips to see if there is an issue with the hips, that they are potentially dislocatable. During this, we'll be observing the baby to really get a thorough understanding that neurologically the baby is perfectly fine. When we're done with that, we get to what I call the most important part of the visit, is what we call anticipatory guidance. What does that mean? This is when we give you a bit of advice of what to do. And often it is going to revolve around some of the questions we ask you the first time. So the advice with feeding will be not only what you're doing now, but what to expect to do between now and the next time you come on into the office, what advances you need to be doing with your baby's food. We will discussing what the developmental milestones you might be able to expect between now and the next visit, for one, so you understand what's going on, and more importantly, so you can know how to keep the house baby safe and baby proof for a child who may, between this visit and next, learn to crawl or learn to pull themselves up, to make sure that we don't have any unforeseen injuries or accidents. When that is all done, I end every visit with one simple statement. Do you have any questions? I tell parents all the time that there is no such thing as a stupid question when you're a new patient and a new parent. You may be reading books about taking care of a child. You may watch videos. You may even be participating in a webinar to see all the information you can glean about how to take care of a child. Many of these sources are going to make you seem like taking care of a baby is black and white. I can promise you for the next 18 to 21 years of your life will be a perpetual shade of gray. There will be no black and whites. So please, 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 we want you to feel as comfortable as possible when you're walking out of our door. You know what to expect and how to take care of your baby. Okay, next break. Okay, I left out a couple aspects of the visit because I knew they were coming up. Before I get the vaccines, I did forget to mention one other thing I do like to talk about. In our visit, we'll often have you fill out a screening tool to give us an idea of other aspects of the child's development. The very first one we'll be doing is usually at about the first week or two of life, I have you do something called a postpartum depression screen. Postpartum depression is a significant problem with moms of newborn babies and may not be seen for the first couple of weeks. And the mother may not see the OBGYN for 6 weeks. So this gives us a chance to make sure the mom is okay, because if the mom's okay, the baby's not going to be okay. Throughout many of the other visits, the 1 month, 2 month, 4 month, 6 months, 9 month visits, we will be handing you a developmental screen, which you can then tell us and fill out to really demonstrate the developmental milestones your baby is making. You can either do that on paper in our office, or very often we'll have you be able to do it online before you come. So this way you could do it in the convenience of your home. And when you go, oh, does my baby actually grasp something like this? You can try it at home before you come into our office. We all have other screening tests at various ages to see if the child has potentially autism. We'll be screening for autism. We'll be screening, doing screens to see if there's a potential risk of lead poisoning and lead exposure. We'll also be doing screening to see if there's potential risks for tuberculosis exposure. So throughout the various visits, you may see these screens coming on through, and this is just our way of getting more information to help you take care of your child. Okay, vaccines. This is a picture of actually Dr. Merkin's partner there, who does a very lovely trick to get the baby not to cry during vaccines. Vaccines are a big, big part of what we do to help protect the children from getting sick. It is actually one of the great medical accomplishments of our society is the development of vaccines. Throughout almost every visit in the first couple of years of life, your baby's going to be receiving immunizations. As a matter of fact, it's going to start even before if we see the baby in our office for the first time. First vaccine that you'll be offered is actually a couple of different vaccines, one for the baby, one potentially for mom. The first vaccine for the baby is the hepatitis B vaccine. Hepatitis B is a virus that's spread through blood contact. And unfortunately, if mom does have hepatitis B during the commingling of blood during birth, the baby will potentially have that virus spread to them. So by giving the vaccine immediately after birth, you can diminish it or really eliminate that risk of happening for the baby. The other vaccine I've mentioned that you may be offered is in the hospitals, we're offering the moms, if you haven't had it already, an adult tetanus pertussis vaccine. Pertussis is whooping cough. This vaccine is probably the most important vaccine when we're giving it to the babies, because it's a vaccine to prevent whooping cough, which in adults is a minimal illness, which gives you a wicked cough that lasts for a couple of months. It's annoying, but you do fine. In babies, it's a life-threatening infection. So we offer it to mom, and I even recommend it to dads, to grandparents who are going to be spending a lot of time with the children to, in a sense, cocoon the baby until we're able to give the baby their own pertussis vaccine to protect them. So at the first visit, you come on in, no vaccines will be given. The second hepatitis B vaccine is given at 1 month of age. And then when we get to the 2-month visit is when we start doing the whole array of vaccines. And Bree, do you want to switch over to the next slide? So you see this picture where it says under vaccines, this looks intimidating. It looks scary to see, oh my gosh, is my child getting all these vaccines? And I'm going to go through what each one is and the importance of them, and then also talk about why it is safe to do. So the first one on that list there is the adult DTaP or the infant DTaP, which is the baby version of the vaccine I was just mentioning for mom. Prevents against whooping cough and tetanus. The next one on the list is the Haemophilus influenza B vaccine, We call it Hib because we don't like to say Haemophilus influenza B all day long. Hib used to be one of the biggest causes of meningitis, infection covering the brain in children. I say used to because we don't see it anymore because the vaccines have done what we've asked it to do. Next is the polio vaccine. In our office, we actually give a vaccine that, it sounds weird, is actually my favorite vaccine because it combines those 3 vaccines into one needle. Why is it my favorite? Contrary to what every child over the age of 3 believes, we are not sadistical people who enjoy sticking sharp objects into young children. This has turned into what used to be 4 needles in a visit to 2 needles. So we actually greatly appreciate that. The next vaccine on the list is the pneumococcal vaccine. Pneumococcus, when we eliminated Hib as the big cause of meningitis in children, pneumococcus moved from number 2 to number 1 on the hit parade. Pneumococcus also tends to cause severe pneumonias. You may have heard this vaccine advertised on TV for senior citizens, and they're offering it now to the seniors to prevent them from getting pneumonia later on in life. And last of the routine vaccines we give is the rotavirus. It's an oral vaccine. Rotavirus is, in short, the worst stomach virus out there, and it is perhaps one of the biggest causes of hospitalizations in young children. They get rotavirus, they get dehydrated and wind up in the hospital for IV fluids until they get over it. So those are vaccines given at 2 months. They're also going to be given at 4 months and 6 months. 9 months, we give the hepatitis B, and those are the vaccines in the first year. Now, often I'll be asked the question, is this too much for my baby? Oh my gosh, look at all those shots. We didn't get so many shots when I was a kid. And you're right, you didn't. We are now protecting against these diseases at a much earlier age, and we're able to protect against more than we're able to when you were a child. But is this too much for the baby? Absolutely not. The scientists who've developing the vaccines have so combed down and so fine-tune these vaccines that the amount of foreign protein called antigens injected with these vaccines is minuscule compared to what you may have received. Let's just take my favorite vaccine, or the one I thought was the most important, the tetanus pertussis. When I was a kid, and maybe when you were kids, you received what's called a whole cell pertussis. In a sense, there were thousands of proteins in this one vaccine. At the current moment, there's 3. So we may have received less different vaccines, but overall, we've had potentially 1,000-fold decreases in the amount of foreign protein put into our babies' bodies as we're protecting more disease. So long story short, yes, it is safe. There has never been a true scientific study to link vaccine causing any harm, causing long-term developmental effect, causing autism. They are safe. Okay, yes, next, Bree.
Dr. Switek, I think you're showing your age. I would say that most of these parents have had...
As I was saying it, I realized I was showing my age. Yes. My son was just right. He's about 24 now. It was just about the time they had just made the acellular switch. So, okay, I'll accept that. But still, the message is the same. The science has gotten better. The amount of foreign protein injected into the baby is much, much, much less than it used to be. It is very, very safe. Okay.
I think the answer is you got it and you did just fine.
Correct.
Meaning you're the parent, because most of these parents have had really all of these vaccines.
Yes. Okay.
Great. Now, Dr. Switek, how do we choose a pediatrician?
Oh, that's a good question. There's a lot of different ways to choose a pediatrician. When I knew that I was going to give him this talk, I was talking to my son who, when he knew one of my topics was how to choose a pediatrician, he said, give him a 1-sentence answer. Tell him to come see you. Well, if that works for you, my office is in Comac. I'd love to have you all come and become my patients. But I've also become to realize that that's not practicable for everybody. So if you cannot come to Comac to see me, how do you pick a pediatrician? How do you choose that? Well, there's a lot of different sources of information. First thing I usually recommend is talk to people that you trust, friends, neighbors, coworkers, people who know you, people who you trust, people who know your personality, know your demeanor, know what will work well for you in that relationship between the doctor and the pediatrician. That's one source of information. A lot of people will talk to their OBGYN and ask them who they should go see, who the pediatrician they recommend, which has been a source of information this way for decades. We always, these days, throw out a little caveat about that because unfortunately, in this day and age, many offices are owned or affiliated with a hospital system or a corporate entity. The OBs may not be as free to fully recommend where they want to go, where they want to recommend you as they had been in the past. So even though they may think Dr. Merkin's the greatest pediatrician in Great Neck, they may not if his practice is not owned by Northwell or ProHealth. So once again, take that with a bit of grain of salt. Other people will turn to websites that rate doctors to see what other people in the community have said about that. Once again, just like if you're looking at Yelp for a review in a restaurant, take one negative review with a grain of salt because you just have somebody who had a bad day. You don't want to take a judgment on the whole practice based on that. With all these different ways, most people come up with a list of pediatricians that are usually in their neighborhood, in their general area that they're thinking about. So my next bit of advice is asking the office to do what we call in my office a meet the parent or meet the mom to see if you can come and talk to the pediatrician, meet the office staff and come in and see the office layout. I know Dr. Merkin was just saying offline beforehand that he's just done his first virtual one of these with a mom. We love doing these things. We have the moms come in, they meet our staff, they get to say hello, they see the layout, how it's run, but then we sit down with them and gives them a chance to ask questions. A lot of questions we'll get is, what's our policy on immunizations? What are the hours? When are checkups? A lot of our parents, both parents are working. They may need evening checkups. Does the office provide that? If my child is sick during the day, what do I do to contact the doctor? What's the policy on answering the phone? What's your policy for sick visits? Do I see a doctor in the office or do I see any doctor that comes in? The whole idea of this is to try to get an understanding if this person, this pediatric group, this clinician, is the right person to help you in a partnership that you're hoping will last for years to help your child grow, mature, and develop into a fine young adult. That's my advice on how to choose a pediatrician.
Dr. Merkin, COVID and newborns.
Okay, so this came up in the chat box as well. With newborns and young children, actually, with COVID, really hasn't been a big concern. They seem to do very well, and this is true even when the pregnant mothers can be at high risk if they do catch COVID, but it seems that the newborns are rather unaffected. And I tell my new parents that from a pediatric standpoint, COVID-19 is less of a concern than influenza, and so I really push influenza vaccine for the family, for the expectant mom. And I tell them not to worry so much about COVID-19. My routine advice that I give when the parents are leaving the hospital with the baby is, this is way before COVID-19 was ever invented or whatever to start circulating, was that for the first 2 months, we like to keep the baby away from as many people as possible. And that's true. That's true now, and that's true long before COVID. So generally, just the immediate family. If there are siblings, in the house, that's fine as long as they're not sick. And generally, the only change in my advice now is that with grandparents, from my point of view, grandparents can be as involved with the baby as the parents are comfortable with. My concern is that we don't wind up giving COVID to the grandparents. So I tell the new parents that as long as they've been careful and they're sure that they don't have COVID in the house, that from a pediatrician's perspective, I say get the grandparents involved right from the start, you know, babies. The patients we've had in our practice with COVID have generally done fine. We haven't hospitalized anyone with COVID since this all began, and even the older teenagers, some of them look like they have a bad case of the flu, but by and large they do fine too. So you still have to maintain, you know, the routine COVID precautions at this point, but this is one of the least things you have to worry about as far as your newborn is concerned. It really is.
Dr. Lidoshore, tell us about self-care for mom.
Okay, so self-care is probably one of the most important things, and somehow it gets overlooked very often. It is obviously more difficult now in the time of COVID to have help in your home, but I agree with Dr. Merkin in that grandparents should be intimately involved if they can be, and whether that involves quarantining beforehand or not, you know, that's a family decision. But in general, moms should be drinking lots of fluid, lots of water. They should be eating healthy as much as possible, at least eating. I know a lot of moms will come in and say, I haven't eaten, I haven't drank anything, I'm half asleep. That's not going to make for a very happy, healthy mom. And the babies can feel that, they can sense that. The other issue is that can lead to decrease in the breast milk, causing an issue with feeding. So it's really important, whether it's your partner or a grandparent, that they allow you to go and take a nap, that, you know, even if you have friends that can't come over, maybe they can leave a meal at your doorstep just to help you out and make sure that you are taking care of yourself.
Dr. Svitek, what about telemedicine? We've been hearing a lot about that.
Sure. Before COVID hit, Allied was rolling out a telemedicine or telehealth platform through all our divisions for our clinicians. Unfortunately, when the pandemic hit, it scared a lot of people, that parents afraid to come into our office. Our staff in our IT department did an incredible amount of yeoman's work to get every physician, every clinician, every office up and running with telemedicine. This way, as our parents were afraid or in panic to come into our office, they at least can reach out to us. We can see their children through telehealth as a way to alleviate that fear. I will admit, when telehealth started, I was not a big fan of it. I am a bit old school, and as Dr. Firestein pointed out, as my children also tell me frequently, I may not be old school, I just may be old, but I'm still a firm believer of hands-on medicine and the importance of the physical exam. So at first, I wasn't a big fan of telehealth. But as we went through COVID, and I saw the look of fear in our patients, and we can see them on the platform, and I can tell that the child was not in respiratory distress, was not having trouble breathing. And I can alleviate that fear that, oh my gosh, this mother does not have to come into my office rushed in right now. They don't have to go to the ER. They don't have to go to an urgent care center. That decreased their anxiety. It also gave us an opportunity to explain what we were doing to keep our offices safe and on what criteria that they should use to bring the child to us to make sure that there's not more we needed to do. Since then, that extreme fear and anxiety has diminished somewhat. There still is some out there, but I've come to realize that telehealth is a great tool in our arsenal of how to take care of children. No, do I believe it's ever going to replace the in-office visit with the hands-on doctoring? No, I don't. But there are a great many uses for when telehealth can be helpful. One, oftentimes we'll use it when a patient can't come into the office. Multiple children and moms overwhelmed and can't get everybody in there. It is just convenience to be able to turn on the phone on the computer and be able to interact with us to make sure their child is okay. I just the other day saw a young lady who was a severely disabled child who's a ventilator dependent, who mom was in tears because she's still deathly afraid of leaving her house with COVID. So I was able to do the visit on telehealth and have her come drive the child in the van, and I finished the last parts I needed to do in the van so the mom and her nurse would feel comfortable her baby, her child was safe, and truly appreciated telehealth at that point. There are other illnesses and medical issues that telehealth is perfect wheelhouse for. Our developmental issues, our attention deficit disorder, and psychological issues like depression and anxiety. Telehealth is perfect for this. These children are on medicines that we may be prescribing or need to be prescribing, and we need to monitor them, and we see them every few months. These visits can easily be done through telehealth with the parent and the child, and this is a great way to extend this for when the child does leave to go to college, and they need to still talk to us about how the medicine's working in that environment. As Dr. Firestein, I saw put in the chat before, skin disorders, brilliant for telehealth. With the technology we have in our phones today, with the quality pictures they can take, with our ability to blow it up, it's almost as good as actually me seeing the skin rash right in front of it. We can see the patient, we can just make the diagnosis, we can treat it electronically and save the patient and the mom a visit into the office. So for these things, I'm a big fan of telehealth. Well, I'm not going to go as far as saying I'm a big fan, but I appreciate it a lot more than I used to.
When we first started with telehealth, I really thought we would say that babies shouldn't use it because, babies are very delicate and we really need to know what's going on. But I found that it's not so much the babies that need it, but the parents, that reassurance, right? Can you look at this spit up? Can you look at this diaper? Can you look at him breathing? Can you look at his eye? Can you look at his belly button? And you know what? Within 5 minutes, a half an hour, you're connected with your doctor, you get that reassurance, and then you can go back to your life without having to, disrupt your whole day and come in and make an appointment. And again, in the times of COVID, potentially expose yourself. But even before COVID, it's hard to get baby out of the house.
Correct.
To dress them and feed them and time it with their naps and stuff like that. So telemedicine has been really useful, I found, for that as well.
Okay, I think the last thing I'm talking about is Allied in general. We, as an organization, we have a great many physicians, and we have meetings, and many of our meetings, which are led by our esteemed leader here, Dr. Firestein, the phrase, "we are allied," is often pronounced. What does that mean? What is allied? Allied is a group of mostly pediatric offices that stretches all the way from north of the city in Orange County, throughout some of the boroughs of the city, throughout Long Island, even all the way out to Riverhead with our Peconic office. We're a bunch of offices that came together to try to do what we do best, to keep the feel of our small office, yet with the support of a bigger organization. We try to do things differently than many of the other larger groups are because we are owned by the physicians in the offices. So this allows us to do what we want to do with one goal in mind, which is the care and well-being of our patients. As I mentioned before, talking with the OBGYN, if you are owned by Northwell, you are obligated to send your patients to Northwell physicians. We're not. If I see your child and your child has a heart murmur, an extra sound in the heart, and I'm concerned, I can choose that Northwell cardiologist I've known for 30 years and say, please take a look at this child. But if the next patient has diabetes and I feel the endocrinologist from Stony Brook is a better choice for your child, I have that freedom to make those choices. I have the independence to choose what is best for your child. Another great thing about what we've done here is the great collaboration that has gone on. Dr. Firestein had mentioned before how and I was talking how with telehealth, we all came together with it. But in general, what's been lovely about being part of Allied is being able to turn to my partners, which are not just the 3 partners in my office, but the partners throughout the organization. I've been at meetings where I might see Dr. Merkin and say, I got a kid with this. What would you do? And it gives me more resources than I may have had. This was never more prevalent and never more proudful to me when COVID hit. We had daily meetings to discuss what we need to do as an organization to keep our patients safe. There was fear, there was anxiety. We got together. How are you doing this? We talked with each other. What are you doing in your office to keep the patients safe? How are you organizing this? How are you organizing your day? All with one goal, is to keep our patients safe. And that's a great part of our collaboration. We work together to try to come up with what's called best practices. And our goals, once again, with those practices are purely for the health and well-being of our patients. And it's through that we're proud to say that we have achieved, every one of our office has achieved a level 3 medical home, which the government offers 2 practices that are providing the highest quality of care. So this is what Allied is. Through it, we've been able to offer other services. I think Dr. Littershaw had mentioned our Allied lactation division. We have pediatricians and teams of lactation consultants and nurses who are at your disposal. If you want to breastfeed and you need support, you're going to get every bit of support. If it does not work, it is not because of the help we've offered you. We will work with families with nutritional issues. We've recently started asthma education. We've put together an asthma care team, an asthma care specialist. Asthma is one of the biggest problems affecting children today, one of the biggest chronic problems. So we know it's a complicated situation. So we have teams of care coordinators who are going to be working with the parents, working with the children to maximize their health and well-being. With regard to telemedicine, understanding the importance of it, we've even developed our own telehealth division. We hired a pediatrician who specialized for years on telehealth medicine to develop this division and work with other doctors that we have hand-selected in Allied to be part of our group to offer an extension of our hours. So if the office is closed, now you can do a telemedicine with an Allied, picked, backed, and vetted doctor who not only is trusted, but has complete access to your medical records and knows all that you've done beforehand, knows any potential allergies and medicines the child's been on. But then also when they're done, that note gets sent right to your primary doctor's computer the next day. When they come on in, they see what happened the night before. It is part of a way that we all communicate, work together, once again, for the health and well-being of our patients. That's why we are Allied.
Thank you, Dr. Switek. So I'm gonna open it up for some questions. So these are some of the questions we got when we asked people to send things in. So, and I'll put this to Dr. Merkin. Since I'm quarantining and we're seeing very few people, is it okay to put off some of those shots that Dr. Switek told us all about until the baby's a little bit older? Oh, you're on mute.
Sorry. It's my first time. So absolutely not a good idea to put off vaccines because these infections, like Dr. Switek said, hepatitis B, they may be exposed to even at delivery. Pertussis, if there's anybody, unless the baby's living in a solitary bubble, the baby can be exposed to pertussis. These vaccines, although they're very effective, they're not 100% effective. So even though the pregnant mother may have received the Tdap vaccine and the father may have gotten a Tdap vaccine and the grandparents, none of the vaccines are 100% effective. So you want to start to get the baby protected as early as possible. So no, we try and stick with the recommended schedule, and even quarantining, even though it seems like you're in a bubble, you're not in a bubble. And kids still get sick.
Right. How many toddlers have you seen? And the parents, you know, the kid has a runny nose at 101 and the parents like, I don't understand. We haven't seen anyone.
Right.
Right. Somehow they've seen someone.
Happens every day.
Yes.
And we are soon hoping to get out of this. If times improve, we're hoping to get out of quarantine. And at that point, you want to have your child protected. You know, when we get to the end of this tunnel, you don't want to sit there and say, oh my gosh, now I have to protect my child and I have to wait another 6 months until they're protected before we can start going to visit family and friends.
We do see less illness, I'd say, overall, since we started all these COVID precautions, but not, you know,
not enough to bet your baby's life.
No.
Speaking of vaccines, do we have any insight into when a COVID vaccine might be available for children?
Sure. Not soon. The current vaccines that are out now, the Pfizer, Moderna, the Pfizer vaccine is approved for children down to the age of 16, Moderna not for children under the age of 18. The best estimate that we're hearing, it's going to be months and months, if not into 2022, before they come out and do the research to prove that it is safe for children to get the COVID vaccine. But on the other hand, for moms, it's important if you get it. We often get asked the question, I'm breastfeeding and they've offered me the COVID vaccine. Is that a safe thing to do? And yes, all lactation organizations, the American College of Obstetrics and Gynecologists have 100% supported the idea that breastfeeding mothers should get the COVID vaccine. And that is a way that we can protect the child through some secondary antibodies made by the mom coming through the breast milk.
And even pregnant moms should get the vaccine.
I think starting next week, they are considered one of the high-risk people that are now eligible for vaccines as pregnancy.
Now they just have to find it in New York. beat their grandmother to the test. Dr. Leitershore, when will my baby start to play with toys or enjoy a bedtime story? And the corollary with that is, you know, when do babies learn to speak?
Okay. So obviously very early on, even in utero, the babies are listening to you singing and talking. And so language acquisition happens very early on. You're going to hear the baby making little noises, which we call cooing, even as early as about a month, but usually around 2 months, you're going to hear a lot more of that. And then in terms of playing, I mean, read books from day one. Absolutely. You should be reading and singing and stimulating the baby when they are awake. But realizing that they need a lot of time to sleep, like I talked about before. In terms of playing, usually you start to see them reaching out to bat toys around 4 months. And between 4 and 5 months, they're rolling over a little bit, so you can get them on a mat on the floor with toys in front of them. And I had mentioned tummy time very briefly before. That is one of the biggest things that you can do for your baby. Now that we have the Back to Sleep campaign, very early on within that, we saw many, many flatheads. And I think as people are recognizing that we have to make time for tummy time, that is decreasing, thankfully. So, you know, get down on the floor with your baby, get the siblings down on the floor with the baby. The floor is the best place for them to learn and develop.
Thank you. I know Dr. Merkin's typing an answer, so I'll ask Dr. Zvitek. How much water should a baby have during their first year of life or their first few months of life?
Really, there's no need for water in the first few months of life. The baby feeding almost exclusively a liquid diet, whether it's breast milk or formula, which is the vast majority or the biggest component is water. So we're not a big fan of using water because if the baby gets used to it, it may diminish the amount of the necessary nutritionally rich milk, whether it's formula or breast milk, they'd be getting. So not a whole lot. No.
Right. I usually say that for babies, feeding is the most exercise they do, right? That's where if they have feeding problems, we find, that they have a heart problem or something because they're having difficulty feeding. So if they're going to be doing that much exercise, they need to be getting some calories because for them, growing is the most important thing.
Correct.
I'm going to address the thing in the news today about the tainted baby foods and things like that, because that's, we've had a few questions like that. And I think the answer is that we don't have a lot of answers right now. What we know is that while the levels they're saying are a little bit higher than recommended, these are not levels that are going to affect a baby's development as far as we know. We're not recommending that anybody get a test, a blood test or a hair test to look for heavy metals or anything like that. The arsenic in rice is an old story that has been going on for probably about 5 years. And I think one of the changes that we've made as pediatricians, instead of saying, okay, start with rice cereal, as we say, start with oatmeal, go to barley, then maybe go back and do a little bit of rice. It's not just the baby foods that are an issue. It's rice that you buy, right? If you make rice for your family, that rice has some arsenic in it. So it's not a matter of just avoiding baby foods. It's about our soils and how our foods are made. And I think the answer is to diversify. Don't give baby too much of any one food. Maybe even try different brands, although I'm not recommending that necessarily. And I do think by the time the babies that are being born now are 4 months old, in a few months, we're going to have some more information on that. But, don't only give carrots, because then in a few years when we find out carrots are a problem, then you're going to feel bad. Go back and forth, try different foods, give variety. That's how you stimulate baby's palate anyway. And that's my recommendation to our parents right now. There's enough things in this world that we need to worry about. You can't make yourself crazy about it. There's mercury in fish, so you just don't give it as many times a week, but they do recommend giving it because there's also omega fatty acids in it. There's nutrition in all of these foods, in addition to whatever toxins, heavy metals there are. Now, as far as organic foods, some of them also had these toxins because, again, they're in the soil, but they may not have some of the impurities as far as pesticides and things like that. So you're still getting less of that if you choose to go organic. If you don't eat organic yourself, it may not be something necessary to do for the baby. Did anybody want to add anything to that? I mean, we just don't have the answers yet, I don't think.
At the risk to put things in perspective, if breast milk was analyzed in the same manner, breast milk is not 100% pure either as far as heavy metals, toxins, etc. I'm still a big proponent of breastfeeding, but you do have to put everything in perspective.
Agreed. I'm just looking to see if there were any other questions. The tummy time, you start as soon as the cord comes off. We're actually at an hour 15. I guess it's pretty much time to end it. We'll do one more. Dr. Karen, what's the difference between spitting up and vomiting?
That's a good question. So spit ups are completely normal. And this is because the lower esophageal sphincter, which is the area between the esophagus and the stomach, is a muscle that's pretty weak initially. So I would say 95% of babies have some degree of reflux, and that's the milk coming back up. You're going to see what's called wet burps. So babies, after they eat, they're going to burp, or you're going to burp them. When they burp, a little bit will come out the side of their mouth. Totally normal. even more than that, they may spit up an hour later, and it could be completely normal. If you notice that the baby has forceful vomiting, that could be a different story. So projectile vomiting we talk about, if it's going across the room, if the baby looks like they're really uncomfortable when it's happening, that's not normal. And so sometimes reflux does need to be treated, and that's something that we would investigate when you come to the office and figure out whether or not treatment is necessary. Some of the things that you can do proactively are reflux precautions. So I tell every parent pretty much to make sure to burp the baby frequently after every ounce or so, unless they're a vigorous feeder and they're not having any spit ups, in which case let them take the bottle, because then it might be more trouble. Keeping them upright after the feeds for about 30 minutes, longer if they have signs of reflux. And, you know, just monitoring and letting us know if it seems like it's abnormal to you.
Yeah, somebody asked about how do you know if it's too much? You know, these individual questions, that's why you want to pick a pediatrician that you're comfortable with, because it's you can't get all the answers in advance. You can't get all the answers from a book because your baby has not read the book. But for the most part, if the baby's gaining weight and they're happy, if they're spitting up, we don't really care about it. But that's a great use, you know, of to start with telemed. If you don't want to wait until your next visit, and then, you know, at your next visit, your doctor will weigh and measure and that kind of stuff. Gaining too fast. There's almost no such thing as gaining too fast. Babies gain the way they're supposed to gain. And mouth breathing, if your baby can take the bottle or the breast, then it doesn't really matter if they're breathing noisily or they seem stuffy, they're not too stuffy. If they're having a difficult time, you can always kind of suck it out either with one of those bulb syringes, or they have the nose free to sucky thing. But another question you can ask your pediatrician. Thank you, everybody. Thank you, panelists. It's been fun as usual.
Thank you. Good night, everyone.
Good night.
Good night, everyone.
Night.